Seattle, Washington, home of some pretty innovative companies that I'm sure most of you have heard of, right? Like Microsoft when it comes to software, Boeing when it comes to aeronautics, Nordstrom's when it comes to like luxury retail, Starbucks when it comes to coffee, Amazon when it comes to like the just-in-time type of retail that's becoming very, very popular now, and Costco, which is wholesale. And a lot of you will be familiar with all these sort of innovative companies. So what I want to talk about is sort of the state of the art. And the definition of state of the art is the highest level of development of a device, technique, or scientific field achieved at a particular time. So let me repeat that again. The highest level of development as of a device, technique, or scientific field achieved at a particular time. So over the years, we've seen kind of an explosion of state-of-the-art types of advancements, even in our own lifetime. So if you sort of think about what something like this is, something as simple as a candle back when before the advent of an incandescent bulb, we can't even imagine what that is like to have no source of light, at night. But that's one of the innovations that Thomas Edison sort of brought to us. Remember these floppy disks? I don't know how many of you guys ever use these floppy disks. I did when I was growing up, and it's kind of funny because back then it was considered like really state of the art. But look at the difference between the floppy disk back then, which is like 256 bytes, to like something like a thumb drive that we have now, which is 4 gigabytes. And now people are starting to talk about like terabytes and petabytes as far as the amount of memory that you can actually store. And 4 gigabytes equals 4,295,000,000 bytes, okay? And so even this is still considered to be sort of like low end of what's possible now. Now with the advent of like cloud technology, right? We're talking about like unlimited ability to store memory, and that was never possible just a few decades ago. And I don't know if you guys all remember like Sony Walkman. I mean, I grew up with a Walkman, and I remember like you see runners with Walkmans in their hands, like running around with these big clunky things. But then now we actually have tiny little devices for MP3 players. And then now we have streaming technology, right? So these are things that probably within the last 5 or 10 years we've only known, but we can't even imagine like not having this technology. And I don't know if you guys remember the typewriter. How many of you guys have ever used a typewriter in your lives? Okay, so a lot of you. But I remember like when you used to write like essays or like assignments and applications, it used to all be on a typewriter, right? Like you'd have to go back and try to erase it. But then now we actually have a laptop computer, and it's just getting thinner and thinner. It's amazing like what technology has done. And then you remember like the movie Wall Street, when they used to have these like really big phones, but back in the day it was amazing that you could have a phone that wasn't plugged into some sort of wall or outlet, right? And now we have these smartphones, which are now essentially it's a computer, it's a high resolution camera, it's a GPS mobile device. I mean, everything that we thought about back then, it's what we have now, and these are things that we take for granted. I see my little nephews and nieces like playing around. They're like masterful with like iPads and iPhones, and so this is something that we truly take for granted. But in reality, these are state-of-the-art advances that have only been around probably for the last decade or two. And if you remember the Encyclopedia Britannica, I mean, like, I grew up in an Asian household. It's like every family had one of these. And if you take a look at like how state-of-the-art these encyclopedias were, they're probably about like 5 or 10 years behind in the current knowledge, right? So by the time it gets published, it's sort of old knowledge, but then we all relied on it. We had to write assignments, and that was sort of considered to be sort of where knowledge was attained. But now we have instantaneous access to live data via like Google search or the Wikipedia, which is constantly being updated by people with that knowledge. So the stream of information now is just like really astounding. So why would we ever choose to go back with any one of these technologies that we take for granted on a day-to-day basis, right? Can you ever imagine going back to those clunky phones? Can you imagine ever going back to the Encyclopedia Britannica? I mean, like, I certainly can't imagine that, but why do we still continue to do that in medicine? And that's sort of a question that I pose to you. Like, how many of you are now currently using electronic medical records? Okay, so probably most of you. It's sort of being mandated here in the United States, and as early as about 5 or 10 years ago, I would say most medical practices were under a paper chart system. Like we were so reliant on that, and the fear of actually going into an electronic medical record system it brought up a lot of apprehension in those of us who had to convert over. But now, for those of us who use it, just like all these technological advances, it's hard to think that we would actually ever go back to a paper-based system with all these charts and walls full of charts and paper protected information that just sits there. So when it comes to some of the innovations in surgical fields, just imagine like what they used to do back in the 1960s and 1970s. You know, if you had a meniscal tear, essentially our orthopedic colleagues would make a midline incision and do a total meniscectomy, and that was the standard of care back then. But now, if you ended up doing that, that would be considered probably malpractice. And so the state of the art or the current technology is essentially just arthroscopic partial meniscectomy. And when it comes to abdominal surgery, you know, if you had like cholecystitis or appendix that was inflamed, you'd either make an open or mini open incision. But now we have laparoscopic technology, and that's kind of a given in what they do in those respective fields. But how about state-of-the-art spine surgery technologies, Fiberoptic Headlights? And these are some slides that I took from my partner, Addison Stone, back in the 1960s. And then surgical magnifying loops also around the same time. So now we had the ability to not only see tiny little areas and have great resolution, but we can actually put that together. And what we do now is really using a microscope or an endoscope to get into the spine without creating undue harm. So that's a picture on your left of a case that I did during my fellowship, and the one on the right is typically how we do spine surgeries now. But are spine surgeons ready to evolve? And that's the question. So I would say that this is one study that I do believe will probably become like a landmark study. It's from the SRS's database of over 108,000 patients, and they took a look at the differences in infection rates, looking at discectomies as well as T-lifts using open versus MIS. When they took a look at the discectomies, they found out that MIS discectomies had about a 3x difference in infection rates comparing MIS to open. When they took a look at their T-lift results, it had nearly a 2x difference in their infection rate, right? So this is coming from the SRS, which is clearly not a minimally invasive society. And this is real data. This is real data coming from the members who do a whole spectrum of different types of surgeries, predominantly open, but also minimally invasive. And you can see that more and more of the members of all of these societies are starting to really do a lot more minimally invasive surgery. So the SRS's conclusion from this paper is that MIS results in 2 to 3 times decrease in the risk of postoperative infection. And this is actually a paper from one of the local surgeons here named Chris Howe. This is when he was at the Harborview, and he was and these are really excellent surgeons who are there. I think Mike Lees was on faculty at the time, and these are really phenomenal surgeons, probably at the top of their game. But even with that type of expertise, there was a high complication rate. There was a 4% mortality rate, mean hospital stay of 12 days plus or minus 7 days, and a mean ICU of 2.7 plus or minus 4 days. So you can see that, like, for those of us that are doing minimally invasive surgery now, it's when you look at these data, I mean, more and more, you just realize like how different it is now to think about that a patient would stay in the hospital upwards of up to a week or two. And under the hands of the experts, 12% experienced at least one major complication, 17% had persistent neurologic deficit, and 35% underwent at least one unplanned return to the OR. So a third of these patients undergoing complex surgeries had to go back into surgery for some sort of revision. But can these complex surgeries be performed using minimally invasive surgery? And I think now we're getting to the point where we certainly can say with pretty good confidence that we can at least have some equivalency in what we're doing. So I'm gonna finish with two cases. And the first is a 45-year-old female diagnosed with adolescent idiopathic scoliosis at 10 years of age, braced for 4 years, presents with 2-year history of low back pain that she rated at 8 out of 10 on a visual analog scale, and anterior thigh pain that she rated at 6 out of 10 on a VAS score. She was taken into surgery for an L5-S1 ALIF with plating by one of the local community docs here, who's a very good surgeon. And then when she came, she said that the surgery did help with her buttock pain, but not necessarily with her back pain or her thigh pain. Her ODI at the time was 46. And so on clinical examination, she was 170 centimeters tall. She weighed 58 kilograms. She was pitched forward 4 centimeters and over to the left 5 centimeters. She had 4 out of 5 quadricep strength in her right quad. She had difficulty with deep-seated squats. She had decreased sensation at the right L2 and L3 dermatomal distributions, and she had a positive femoral stretch test on the right. She had a left lumbar prominence with forward bending. This is some of the x-rays showed 40 degrees left apex lumbar degenerative scoliosis. And as mentioned, she's pitched forward and to the left, and this is what she looked like. So you can see that she's got significant lateral listhesis at L3-4. She's got pretty significant lumbar degenerative curve. And then she has this focal kyphosis between T11 to L2. And plumb line falls over to the left and a little bit anterior. The MRIs showed evidence of lateral recess and foraminal stenosis at the concavities of both the major curve as well as the lumbosacral fractional curve. And then there was foraminal stenosis also at the concavities of each of the curves. So her diagnosis was lumbar scoliosis status post L5-S1 ALIF. So this is when you should pull out your iPads, and then you can see that these are the options. So if you could vote for one, that'd be great. The first option is a T10 to L5 open posterolateral fusion. That's option 1. Option 2 is L1 through L5 lateral lumbar interbody fusions with percutaneous pedicle screws. Option 3 is L1 through L5 L-lifts with open pedicle screws. So that's the difference between 2 and 3. One is percutaneous pedicle screws and the other one's open. And the fourth option is L1 through L4 L-lift and L4-5 T-lift with percutaneous pedicle screws. So if you could just take 1 minute just to vote for that, and you can sort of see live what the consensus is, if there is going to be a consensus. It's a horse race. American Pharaoh, come on. So it looks like American Pharaoh's lateral lumbar interbody. Oh, wait a minute. I don't want to speak too fast. But it's interesting because like when we would take these sort of informal polls earlier, we would notice that a lot of like the majority would be open, but you can see that there's a preponderance of the percutaneous techniques. So it looks like we have the majority, 50% would do lateral lumbar interbody fusion L1-5 with perc screws, and then 38 would do the same thing except for an L4-5 T-lift. Any comments from any of the either the faculty members or the audience out there as far as why you chose what you did? Niels, do you have a comment?
Well, I guess the access to the L5 segment in some cases might be difficult. So you want to have a look at the MRI scan before you make the decision that you can get access to the segment from that or not. That would be my trigger to distinguish between the two.
Got it. But you would do one or the other though, right? Okay, got it. Any other comments? No? Okay. So what I did was L1 through 5 lateral lumbar interbody fusion as a first stage. And so we essentially did L-lifts, or you can call them D-lifts or X-lifts. They're all the same type of procedure. And then, so if I were to sort of just like sort of critique myself, I wasn't really happy with the L1-2, because what I do is I go through the concavity because I believe that you should release what's tight, and that's in the concavity. And a lot of the osteophytes are typically in the concavity. And that was the case that we actually did this past week, or I'm sorry, on Wednesday. And by the way, that lady's going home today, So we did an L2 through S1 this past Wednesday, and we had one level at L4-5 that was just arthrodese, at that concavity. But the reason why I like to actually approach it from the concavity is because you can actually do a resection of that osteophyte with an osteotome. The reason why like L1-2 here just doesn't look very good to me, but it's stable. But sometimes you can get into that if you try to make the incision too small and you're trying the angle's not perfectly where you need to be. So typically what I'll do is I'll try to access the most difficult levels. In this case, I would probably access 4-5 and then go to L1-2, then 3-4, then 2-3. And what that does is it allows, because if you end up going from middle to outside, what ends up happening is those outer ones like L4-5, it kicks out away from you and the crest can get in the way. So always try to do the most difficult levels first. And then the stage 2, we did a T10 to L5 percutaneous instrumented posterior spinal fusion. And so we essentially did perc screws. I can't remember why we left out one level, and I can't really recall. I don't think it was because of a small pedicle, but we did that, which is fine, no problem, because the large interbody cages are very stable. So we got pretty good correction from 40 degrees down to 4 degrees. And the nice thing about this is also that lateral listhesis. And as you know, the listhesis is what can cause the severe stenosis, is also corrected by utilizing this technique. And this is what it looks like from pre-op to post-op. And the overall balance on the lateral view is also pretty good. The 28 degrees, because you're able to use these lordotic cages, you're able to sort of restore that lordosis as well. Sort of longer term follow-up at 1 year. Back VAS scores was from 8 out of 10 to 3 out of 10. Right leg VAS from 6 out of 10 to 0, and ODI from 46 to 24. I mean, I think you should be following up for her 2-year, if not already, then soon. The second case is 57-year-old female, also diagnosed with AIS as a teenager, history of progressive left-sided thoracic and right-sided lumbar humps, worsening pain in the thoracolumbar, prominence in the left leg, lost 2 inches over the past few years. Physical examination, 38-degree right apex from T4 to 7, 60 degrees on the left from T7 to T12, and 40 degrees from L1 through L4. And this is what it looked like, sort of a double major, almost a double major with a compensatory curve at the level above, and a lumbosacral fractional curve. This is what the MRIs look like. So again, pretty typical, like lateral listhesis, big osteophytes, collapsed disc spaces at the concavities. So the diagnosis is adult idiopathic thoracolumbar scoliosis. And so again, if you guys could vote, option number 1, would you do an open posterolateral only fusion? And this one's kind of tricky. Number 2 would be thoracic and lateral lumbar interbody fusions with percutaneous screws. And the third option is thoracic and lateral lumbar interbody fusions with open pedicle screws. So what would you vote for? Or other. If you can think of another option, please vote for that option. Okay. Interesting. So this one is really controversial. Like if you present something like this at the SRS, typically they'll try to skewer you because the thought of doing lateral interbody fusion in the lumbar spine is pretty acceptable now, right? Like most people wouldn't say anything, but to do it in a thoracic spine can be somewhat controversial. And as you know, like the right thoracic curve is the most common pattern, and if you are trying to get it from the concavity, you'll notice that you'll often run into either the heart or the aorta, and so it'll often be in your way. So you have to oftentimes go into the convexity just by nature of the fact that you have vital structures in your way. But this is really interesting because this second option, I wouldn't have thought that, actually, to tell you quite honestly. And this is sort of one of the conundrums of doing percutaneous screws, right? If you don't have lateral lumbar interbody fusions, then how do you fuse it, right? It can't just be an instrumentation without fusion. And then the other option is, do you do perc facet fusions at every single level, which can be like so tedious, right? And is that enough of a fusion to hold the fusion? But the way I like to think about this is like when you think about growing rods, when kids have growing rods, what you typically tend to do is go hit the apex and fuse the apices, and then allow the child to grow during the adolescent years and allow that to grow. But you really want to get your correction right at the apex. So if you have a situation like this where you have a double major curve, you want to address each of the apices, do the correction as well as the fusion, and then in between you can do facet fusions. And at L5S1, typically like either an A-LIF or T-LIF. So that's what we did. Was first stage we did a thoracic and lumbar L-lifts. And so this is hard to see, so I apologize this picture. And I got to be quite honest, like even now, you don't really get a great correction in the thoracic spine when you're doing the lateral lumbar interbody fusions, but I think what it does is it loosens it, it releases it in the concavity, and it allows the instrumentation to actually give you the correction that you need, whereas before it was still a very stiff curve. And remember, these are patients that are like adults now. These are not like adolescents with very flexible curves. These are adults with very stiff curves. So when you see a picture like this after doing the first stage, don't be discouraged, because that second stage, when you have the instrumentation and you're able to do the reduction techniques, that's what really gives you the ability to correct the scoliosis. So the second stage is the percutaneous ES2 posterior spinal fusion. And then this is, I mean, when you start doing these cases, it does become a matter of being very good manager of guide wires. You know, very often, or very much like what sports medicine guys do with like suture management when they have multiple sutures coming out of the skin, right? So you have to. What I like to do is I like to actually label these. So I like to know which guide wire is going at which level, and then you want to know which level from which level is which level is the thoracic curve and which level is the lumbar curve, because you're going to want to know where to compress and distract and where to do your derotation. So all the concepts that you learned in open deformity correction, all those things hold true. So when you first take a look at this, taking a look at the sagittal balance is one of the major keys of making this successful. So the first thing that I'll do is that I'll actually, let me just go back one. I'll actually draw a line. You can't really see this very well, but you can see that over here. Let's see if this, okay, this is better. You can see over here, I've drawn lines sort of, I'll take one long AP view. So here's the midline, and that's the spinous process, right? On either side, these lines here, what I do is I take a guide wire and I sort of map out where I think I'm going to put the skin incision, okay? So I've sort of written out where I'm going to put that skin incision, and based on this line, I don't want to veer too medial or lateral from that line. So meaning that if I have 3 guide wires, I don't want to go medial, lateral, medial, because what you'll end up with a screw head alignment that looks like this. And then when you start putting in your rod, it's going to be very difficult to get that down into that area. So if you sort of stay medial, then try to stay on medial of that line, or if you stay lateral, try to stay lateral on that line. So at the very end, you'll be on the same sagittal plane, and that'll make your rod insertion much easier. And I'll show you what I mean by that. Because when you take a look at the sagittal balance, you look straight down the pike, right? So what I'll do is, after I put these guide wires, I sort of look at right down on the sagittal plane. And I'm always looking at that. I'm always allowing the rods, the guide wires to come back up, so I know what the alignment is, right? Because if I'm putting these guide wires right down the center of the pedicle of every single level, I'm wanting to see what that alignment is. And when you first see this, you can see it looks very like chaotic. There's no rhyme or reason behind how this is, and that's because the spine itself, the alignment is chaotic, right? So at the very end, you're going to want to line everything up. But once you put the screws in, then you can take a look at a little bit better idea of how this alignment is. And now you can sort of see sort of this pattern of this double major curve, right? So I look either cranial caudal or caudal cranial, and you can kind of see what kind of shape this spine is in real time right now. But it's not until you start contouring the rod, and the nice thing about the ES2 system now is that you can actually contour the rod, so you can get an idea of what the length of the rod is going to be, as well as what the shape of the rod should be as well. And instead of previously, I think the concept behind scoliosis reconstruction was you put the rod in and then you bend the rod to fit the spine, right? Because remember, you do sort of inside to and then you bend the rod to try to straighten it out. But now I think MIS scoliosis reconstruction is much more about you bend the rod like you want the alignment to be, sort of best fit to where the spine is. But then now because you've done those releases, you're bringing that flexible spine up to that rod. Does that make sense? So you've contoured this rod to make it fit like you want this patient to stand. Then now you're bringing each of those segments up to the rod itself, okay? So if you've done a good job of keeping all those spines in a relatively sagittal plane, then that's going to make that job that much easier for you. So then you introduce the rod, and I can tell you right now, like, and the Australian surgeons can attest to this, right? If you can line up the guide wires as much as possible in the sagittal plane, it can cascade. You just don't want it to be looking like this, but it can sort of cascade in a curve. So if it looks like it's curvilinear, that's okay, because that's the way it should be. Because once you introduce the rod and then you do the derotation maneuver, the spine will come up to the rod itself. And then once you use the power of the reducing blocker nuts, that spine will come up to the shape of your rod. And then so what you'll see is it starts becoming straight, because now it starts conforming to the shape of the rod itself, right? So before, I think what was happening is when we were just doing posterior only open fusions, what was happening is, and you hear about like pedicle screws pulling out of osteoporotic bone, we were trying to force the bones to conform to the shape to the metal, which is, I think, a huge mistake, right? Now the thinking is release everything and make it more flexible and bring it up to the rod itself. And so you'll see that when you take a look at the sagittal balance now, everything starts becoming straight, right? So that's why I think this is critically important in managing scoliosis. Now you can see down here, it looks like it's almost like very straight in that sagittal plane. So that's the major difference, and that's sort of what we aim for now is sagittal balance here. And then the same types of maneuvers, you'll want to maintain that, meaning that after you do the derotation, then you want to compress through the convexity and distract through the concavity. So that's why it's critically important for you to know exactly which guide wires relate to which vertebral level, because you want to know where you want to distract and where you want to compress. And so you end up with pretty decent results. Like before, I trained with Dr. Boachi at HSS. He used to always say like 50% correction in adult deformity is a good result, right? So I feel like now we're getting equivalent results by using these minimally invasive techniques. And really it's a sagittal balance, just maintaining that good sagittal alignment, restoring that normal lumbar lordosis, maintaining that thoracic kyphosis to where it's anatomic. I think those are the keys now. So what are the patients to make of it all? Do I have anyone here from the Laser Spine Institute? Because I don't want to offend anybody. Right? You are not from Laser Spine Institute. So a few years ago, I did like a Google search on minimally invasive surgery, right? And then the first thing that pops up is this thing called the minimally invasive option. And it comes up www.northamericanspine.com. I don't know if you've heard that or not. But it says, we offer the least invasive of the minimally invasive spine surgeries. Okay, the least invasive of the minimally invasive spine surgeries. Number one Google hit. And they call themselves North American Spine, kind of like North American Spine Society, right? So then you click on that, and then you get to their website, and it says North American Spine, the leader in minimally invasive spine care. They don't use surgery, but they use care. So we're like, okay, who are these guys? Where are they from? Who we are not. So they define, this is off their website, by the way. I just checked yesterday, and they have something that's different now. So I don't know what's going on, but they're using a different tactic. But they are not traditional spine surgeons. That's what we know. They are not traditional spine surgeons. So North American Spine, you sort of like kind of browse their website, and they do this thing called the Accurascope procedure. And it says you can treat multiple levels with a single incision. Okay, it sounds like surgery. You make an incision, you treat this problem. It's like, okay, a single 3 millimeter incision is made in the skin above the natural opening at the base of the sacrum. All right, sounds like surgery to me. A steerable catheter is inserted through the natural opening so that an endoscopic camera and other instruments can be guided through the spinal canal. All right, that sounds like surgery to me. So they go to the offending disc and they zap it with a laser. Okay, this is real. This is a real deal. And then, who are they? They're pain management specialists. This is like these guys are interventional pain management specialists. They're like anesthesiologists, like pretending to be spine surgeons, and they come up number one when you do a search of minimally invasive spine surgery. So like, are you kidding me? So there's a lot of like hocus pocus bait and switch out there, and this is what we're competing against right now, you know? So what I'm telling you right now is that if we don't embrace MIS and take it for what it is, others will definitely embrace it for us. And we should learn, we're surgeons, right? We should learn from the learnings of what happened with vascular surgery. So vascular surgery, they did open procedures, open AAA repair, open vascular stripping, right? And now the interventional radiologists, they're doing everything endovascularly, and vascular surgeons almost lost out to that. They did. They almost lost a huge segment of their business. And so now they have endoscopic vascular fellowships, and that's all they do now. Like that's sort of the state of the art in vascular surgery. Is like the vascular surgeons, like my good friends who are vascular surgeons, when I see them, they look like radiologists in their surgical suites because they're doing it through tiny little incisions, and it's really more needle based. And I believe that that's where we're headed. The next stage, going from tube-based to endoscopic, then it's going to be some sort of needle-based. I do believe that thing about this Accurascope, we're going to look back and think, my God, that they were on it. They understood where the next phase should be. So instead of sort of poo-pooing the technology, we should be sort of fearful about our colleagues who are not surgeons, who are sort of advertising that they are. Okay. So in summary, surgical treatment of scoliosis and these complex surgeries, it can be fraught with a lot of complications. We have to be honest with our complications. We still get complications. We should be very honest with our complications. I got to tell you quite honestly that patient that we operated on Wednesday, she has weakness of her iliopsoas. I mean, I'm just being very honest about that. We'll talk about that. We should be openly talk about our complications, our known complications. But we should also recognize that these are complications that are time limited, and we should understand the anatomy and physiology of why this occurs. Why do these complications occur? Because if you went through your biceps with a tube, the next day you'd have a difficult time lifting things up with your bicep, right? So when you go through the psoas, you're going to have a hard time lifting up a heavy leg. But if you injure an L4 nerve root, you're going to have a permanent inability, maybe even a foot drop, quadricep weakness. Those are real complications. We have to be honest with ourselves about these complications. So I would advise and sort of ask all the faculty members and all the participants to really be open about this. We're still learning. We're still in the process, that phase of and curve of learning. We're still in the early phases of that. So I really want us to all be very open about what we're learning here. Thank you.